Hello, my name is Dr. Stuart Sherman, and I am Professor of Medicine and Radiology, the Glenn A. Lehman Professor of Gastroenterology, and the Director of our Advanced Endoscopy program at IU Health, Indiana University School of Medicine. I'm here today with Dr. Mark Gromski, Assistant Professor of Medicine at the IU School of Medicine, and my colleague on the ERCP team. We are very pleased and honored to have been asked by the editorial team of Gastrointestinal Endoscopy to speak to you today discussing our paper entitled Double High-Level Disinfection versus Liquid Chemical Sterilization for Reprocessing Duodenoscopes Used for ERCP, a prospective randomized study. The topic of transmission of infections through duodenoscopes and duodenoscope reprocessing is a highly publicized and also important topic. Mark, can you please discuss our motivation for undertaking this study?
Thanks, Dr. Sherman. I'd be happy to. When this study was first devised, there were innumerable unanswered questions regarding the ideal way to approach the problem of duodenoscope reprocessing and the ideal way to limit the risk of transmission of infection. Even today, we still have some unanswered questions. I think it's best to briefly review the problem. In the fall of 2013, the CDC alerted the FDA of the potential association between multi-drug-resistant bacteria and duodenoscopes. Since then, there have been a series of safety communications from the FDA. One of those, in August of 2015, offered supplemental measures to enhance duodenoscope reprocessing. These 4 supplemental measures included microbiological culturing of duodenoscopes, reprocessing with repeat high-level disinfection, reprocessing with liquid chemical sterilization, or using ethylene oxide sterilization. Now at IU, we had already had a surveillance protocol in place where we cultured a certain percentage of our duodenoscopes routinely, and we had already instituted double high-level disinfection. This experience was published in 2018. This current study was devised as a way to internally decide whether an alternative supplemental measure noted by the FDA, that is, liquid chemical sterilization, would outperform our current process at that time of double high-level disinfection.
Thanks, Mark, for providing that detailed background for us. Can you now tell us briefly the design of our study?
Sure, I'd be happy to. From October 2017 to September 2018, we randomly allocated each of our duodenoscopes to being reprocessed by either double high-level disinfection or liquid chemical sterilization. The scopes stayed in that reprocessing group for the duration of the study. Patients, physicians, and procedural nurses were all blinded to the reprocessing strategy. The duodenoscopes were randomly cultured after reprocessing. Approximately 30% of the duodenoscopes were cultured per week. Our infection prevention specialists performed periodic evaluations of the duodenoscope culture process and the distribution of duodenoscopes to ensure that they were cultured in an equitable fashion. The aim of the study was to compare the efficacy of reprocessing duodenoscopes by the 2 strategies by evaluating the post-reprocessing surveillance cultures obtained.
Excellent, Mark. Can you now summarize for us what we found in the study?
I'd be happy to. During the study period, we had 878 scopes cultured after reprocessing. There were 453 in the double high-level disinfection group and 425 in the liquid chemical sterilization group. Of all the cultures, 1.9% were positive for any organism. There was no difference in positive cultures between the 2 reprocessing strategies. Specifically, there were 8 positive cultures in the double high-level disinfection group, and there were 9 positive cultures in the liquid chemical sterilization group. There was no significant difference between those 2 groups. Both had 2 cultures that grew high concern organisms, but no multi-drug resistant organisms were detected.
Excellent. Now we have a lot of different types of duodenoscopes we use. Did the type of scope make a difference in the positive culture rate?
It's a good question. We did find that numerically the older model duodenoscopes, that is for us the Olympus 140 model, the Olympus 130 model, they did have a slightly higher percentage of positive cultures compared to the newer model duodenoscopes, for us the Olympus 160 and the 180 models. The positive rate was 3.7% in the older models and 1.3% in the newer models. but this did not reach statistical significance. The p-value was 0.16. It is possible that with a larger sample size, this may have been determined with more certainty.
What about the time and cost of the two different reprocessing strategies?
These are important questions. All health systems and hospitals do have different contract prices, but for our hospital, the capital expenses of the reprocessors and the recurring costs, that is the cost of the disinfectant, the testing solutions, the testing strips, were similar between the two strategies. Given we had previously been performing double high-level disinfection, our scope cleaning technicians did subjectively prefer this strategy. This is likely because they were more familiar with it from the start. The complete reprocessing cycle time for the double high-level disinfection was about 98 minutes, and it was about 55 minutes for the liquid chemical sterilization strategy, although we did not prospectively track these times for each case.
Thanks, Mark. I think those are the important points of the study. In summary, we can take away that there was really no winner and no loser between the two reprocessing strategies for ERCP scopes. Although neither strategy completely eliminated positive cultures, they both resulted in quite low rates of positive cultures after the supplemental reprocessing measures in each strategy were initiated. I'd like to thank you, Mark, for discussing this paper with me today. And again, we'd like to thank the editorial team of Gastrointestinal Endoscopy for giving us this opportunity to discuss our paper. Thank you.